Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, and welcome to GasGasGas. Today we are chatting Ropivacaine. Now, if you get asked this in an exam and your brain's jangling along and you need some stuff to say whilst you're actually thinking about the rest of the answer, then you could open with Ropivacaine is structurally very similar to bupivacaine. They're both amide anaesthetics. It is, however, described as causing less motor block in relative terms compared to other local anaesthetic agents. Of note, it is enantiomerically pure and is made up of the S enantiomer. Much like levobupivacaine, this enantiomer favours cardiac sodium channels less, i.e. it's less cardiotoxic. We're going to get into the rest of the bulk of it in a moment, but I just wanted to say, folks, if you haven't subscribed to the show yet, what are you waiting for? This is great, at least I think it is. Make sure you check out the show notes in the podcast description, take you to the website, all the information's there. And if this podcast is happening to preserve your sanity, feel free to fire off a donation. There's a link there in the show notes and support the podcast. Anyway, now we've got that out of the way, let's get on with the show. Full name, Ropivacaine hydrochloride monohydrate. Brand name, Naropin, or Naropin, depending on how you pronounce things. This is an amide local anaesthetic agent, and it is of the hypocoxylide stem/group. How is it presented? Well, it's a clear and colourless solution, and it is a pure enantiomeric preparation of S-Ropivacaine. It comes in 0.25, 0.5, 0.75, and I think 1% concentrations. There are no adrenaline mixes pre-made with this, as it doesn't alter kinetics. And there is also a hyperbaric preparation, which can be used for spinal anaesthesia. However, of note, there isn't a UK licence for its intrathecal use. I'm sure people still do it. Now, you're probably thinking, why, Dr. Gas, are you bothering to talk about Ropivacaine? I've never seen that in the cupboard. And arguably, I hadn't seen it into the cupboard until like a year or two ago, where there was actually a shortage of levobupivacaine, courtesy of probably Brexit, or just someone forgetting to press a big button that's like on the wall in some warehouse that says order more bupivacaine, and actually places were having to reach for Ropivacaine because they could get hold of it. So I think it's important to have at least a approximate understanding of this drug, so that when someone forgets to press that big red bupivacaine order button, maybe we can reach for Ropivacaine and not be completely clueless. So we're going to talk pharmacodynamics of Ropivacaine. But now comes part of the show where I describe how local anaesthetics work in a different way for the umpteenth time, because it's going to fit into your brain and stay there. So, you squirt some local anaesthetic on a nerve, and it doesn't just tell the nerve to shut up from the outside, it has to get inside the nerve, really get under its skin in order to work. So it has to transit across the neurolemma, aka the membrane of the nerve. To do this, it has to be in its unionised form. However, as we well know, most local anaesthetic agents prefer to be ionised than unionised. So there's a small fraction that can get under the skin of that nerve to exert its effect. So, now we've got the unionised fraction, it's soaked into that nerve, we're inside our neuron floating around in cytoplasm, we've got our eyes locked onto that internal aspect of a sodium channel, and we're like, yeah, come on then. However, unfortunately, we're not the right shape for that sodium channel in our unionised form, so we have to go and ionise again. And as such, make friends with a hydrogen ion, change shape, and then get stuck in, quite literally, to that sodium channel, causing blockade. Now we know that a sodium channel that's giving our local anaesthetic a bit of aggro and opening its mouth is actually more susceptible to that local getting stuck in its mouth being channel here, folks. And that's how local anaesthetics work. Anyway, we're going to look at clinical uses of Ropivacaine now. So it's generally going to be used for regional anaesthesia and epidural anaesthesia. It is not licensed, as I said, for spinal anaesthesia in the UK. Dosing wise, well, the toxic dose is 3 milligrams per kilo, so you shouldn't give that. Below that, it's probably site specific, isn't it? Because you can squirt quite a lot in for a volume block, but less if you're ultrasounding right next to a nerve. Now, interestingly, sensory block onset times for Ropivacaine are similar to bupivacaine. whereas motor blockade takes longer to develop. So you might have a patient with numb legs who can wave them all around and might find it all very strange and discoordinate if their proprioception is gone, but their muscles still work. They might be quite almost ataxic, I suppose. The converse is true for recovery, in that sensory blockade persists for a similar time to bupivacaine, whereas the motor blockade recedes more quickly. Of note, if anyone were to ask you and back you into a corner, a appropriate spinal dose is 15 milligrams of ropivacaine, which is similar to what we might stick in bupivacaine-wise. Moving on from the clinical uses of ropivacaine in our pharmacodynamics section, we need to think about the side effect profile of ropivacaine, and you can probably guess that it is quite similar to other local anaesthetic agents. So I'm not going to pile deep into this, but I want to be able to convey that you can say it is less cardiotoxic than bupivacaine. And you could raise that argument and support it by suggesting that the toxic dose is 3 milligrams per kilo for ropivacaine versus lower amounts for the other agents. Naturally, it is still cardiotoxic, and if you were to squirt it all into someone's vein, artery, etc., you will end up with side effects. Now, from a cardiovascular perspective, there's an interesting biphasic response with ropivacaine, much like there is with other agents, in that initially you get a little bit of a blip of high blood pressure, which gives way to hypotension as the plasma concentration climbs, ultimately leading to conduction issues and VF, asystole, VT, whatever floats your boat. It seems to have a tendency to do it all. And then from a central nervous system perspective, again, you will see that biphasic response where they get altered sensorium with some excitability of that sensation, agitation, seizures, coma, death. But remember, this is reversible CNS blockade, much like it's reversible on your spinal cord, it's reversible in your brain. Just takes a while. Pharmacokinetics of ropivacaine. So the absorption characteristics of local anaesthetics again stand here. So intercostal, i.e. your ribs, very well perfused, soaks up local anaesthetic quite merrily, relative to caudal injections, i.e. through that sacral hiatus, quite good at soaking it up, not as much as your ribs. Epidural injections, you'll find that in the middle ground. Brachial plexus, less blood flow in there, soaks up slower, and subcutaneous, which, as we all know, is going to have the slowest uptake profile of local anaesthetics out of everything we're doing, unless I guess maybe you squirt it on their toenail. I'm sure that has less blood flow. Distribution-wise, so conveniently, its pKa is the same as bupivacaine. It is 8.1, which means it is 15% unionized at physiological pH. It is 94% protein bound, which, just to be moderately awkward, bupivacaine is 95% protein bound. But they both favour alpha-1 acid glycoproteins as their chief site of binding, although I think it probably also binds to albumin, if anyone's asking to quote you on that. Alpha-1 acid glycoproteins for local anaesthetic drugs. Its volume of distribution is 52 to 66 litres, which is massive, but it's going to soak into people. It's quite lipophilic. It wants to go where it needs to go. How is it metabolised? Well, you should be able to tell me by now that as it is an amide, local anaesthetic agent, the liver is getting busy. It breaks it down by hydroxylation, and it uses CYP1A2 and CYP3A4. Now, the important thing here is that technically you can find a patient who has been taking drugs that inhibit these agents. Now, for CYP1A2, I think it's some pretty niche drugs here. For those who are deeply curious, the drugs that would inhibit CYP1A2 are enoxacin, and that's a fluoroquinolone antibiotic, like ciprofloxacin, enoxacin, and fluvoxamine, which is a selective serotonin reuptake inhibitor used to treat OCD. Now, these aren't common agents in UK practice, so I don't think we need to stress too much about that. And then CYP3A4, so that is classically inhibited by fluconazole. Now, in terms of which of these enzymes has the dominant role, it's probably the CYP1A2, because if you inhibit that, you get a marked increase in plasma levels, whereas with the 3A4, it's only a 15% increase. So conveniently for us, not that it's probably too much of an issue anyway, we don't need to worry about drugs really inhibiting the clearance of ropivacaine. It might come to play if you're abroad and a patient was on enoxacin for some sort of renal tract infection, and then you were using an infusion of ropivacaine into their epidural space for some reason, then maybe you might start seeing toxic plasma levels and you might have to think a bit harder. Unlikely in the UK. Its clearance is 0.4 to 0.8 litres per minute, and the elimination half-life is an hour to just under 3 hours. That is ropivacaine in a nutshell. It's important just to have a grip of how it compares to other drugs more than perhaps knowing how to reach for it in your day-to-day practice, unless, of course, you're in a hospital which uses ropivacaine, which certainly exists in the UK. And if you do, drop us a comment and describe how you guys use it. It'll be interesting. Are you sticking it in spinals? Are you doing it off license? Gosh. Now, I've only been talking for the grand total of like 10 minutes, so I'm going to indulge a bit of spinal history. We've already touched on, in our cocaine episode, sticking cocaine in people's intrathecal spaces causing awful headaches, but then being able to whack people in the shins with hammers. But now we're going to talk a little bit more about the potted history in the 20th century when it comes to spinals. So everyone's probably heard of Dr. Beer sticking cocaine in people's backs, and then the folks who developed these needles, Sprott and Whittaker and all that, and Toohey. And I think we're all pretty accepting that when you're using massive needles, you cause headaches and you might prang nerves, or you're in an area of the back and body where you're not quite sure what the side effect profile is. And that's really where history takes us. And it occurred in 1947, and it was at Chesterfield Royal Hospital when Mr. Albert Woolley and Mr. Cecil Rowe developed devastating paraplegia following a spinal anaesthetic. Same day, same list, same anaesthetist. Now, before all this, there were other documented side effects in the literature, people getting sort of like a chronic arachnoiditis picture, infections, epidural abscesses, hematomas, etc., etc., etc. All a bit non-specific and a bit unclear. In 1936, there was a paper that described patients developing meningitis, radiculitis, cauda equinas, and transverse myelitis. And there was a lot of documentation, but no clear, no one's going to organise a national audit project in 1947. But what happened with Mr. Woolley and Mr. Rowe? Well, they were terribly injured, and they sought compensation through the High Court. Ultimately, the High Court ruled against them seeking compensation based on evidence given by other physicians at the time. Ultimately, they decided that the phenol they were using to clean the outside of the ampules and sterilise them before they were used to do a spinal anaesthetic had been seeping through micro cracks in the ampules, contaminating them, and that's what happened to cause these devastating complications. At the time, this really knocked back the use of spinal anaesthesia in UK practice, as concurrently neuromuscular blocking drugs and halothane, a non-flammable volatile anaesthetic agent, were becoming popularised, rendering general anaesthesia quite a bit safer and causing a lot of perceived concern about administering spinal anaesthetics if you could avoid them. This is counter to how general anaesthesia and spinal anaesthesia bore out prior to neuromuscular blocking agents and a safer volatile anaesthetic, because surgeons quite liked patients who'd had spinal anaesthesia because they didn't wriggle, they didn't move, they were delightfully flaccid, and they could operate on a convenient surgical field, whereas patients under ether anaesthesia, etc., bit wrigglier, weren't paralysed, more challenging. But what perhaps really happened, now you could say, well, that anaesthetist just pranged them with a needle and wasn't paying attention, and you could focus down on the practitioner, but also it's unusual that this event happened twice, same day, same anaesthetist, same list. And you have to look towards the equipment used. Nowadays, we use one spinal needle, goes in a sharps bin, whereas they used to reuse equipment, syringes, needles, and they would sterilise them. And unfortunately, I think we are looking at an early multiple holes through cheese event in that the sterilising equipment had got quite scaled up. And when I say scaled up, folks, remember that depending on the nature of your water and if you're on limestone or not, you can actually have quite a lot of calcium carbonate in your water, and that furs up things that get boiled in, i.e. you get fairy kettles full of calcium carbonate, and you've got to knock it off, scrape it off, or just ignore it. But naturally, if you're using it in an environment where you're trying to sterilise things and you've got more nooks and crannies courtesy of scaling, then you need to do something about it. Now, this is only supposition because there's no true proof of this. But the theatre sister, who would normally have supervised the sterilisation process on this day, unfortunately left work early because she was very ill. She was profusely vomiting and had a headache. Now, you could wonder what the differential diagnosis for that might be, but actually she ended up with a pituitary tumour being successfully removed later on, hole in the cheese. Therefore, this descaling process hadn't really been completely completed. No one rinsed out the tank and then sterilised the necessary kit. This kit was then used. Unfortunately, it had a little bit of unplanned acid on it. Now, you can imagine putting acid into an intrathecal space causes quite a lot of mischief, and it's something we wouldn't do. And this is what they think is the cause for the unfortunate neurological sequelae occurring. Now, in terms of the verdict, the judges said that anyone performing a task should be expected to do that to the average of all those around them who perform that task, i.e. you shouldn't expect an individual to be in the top centile performing spinal anaesthesias, and that someone who's at 50% of the centile may get just as many complications and side effects, and it's not their fault. However, the way that legislation and sort of medical law in the UK bore out at the time meant that nobody was then to blame, and these people got no compensation, and that wouldn't happen these days. I'm not a medical legal lawyer, so I'm not going to go in more detail on that. Suffice to say, I was just more interested in the mysterious cheese model that occurred to lead to this complication that has been designed out by virtue of single-use equipment. But I think it does highlight that we have to be absolutely vigilant when doing spinal anaesthetics, that we don't unsheath our spinal needle and put it back down until we're actually going to use it. We do appropriate sterile technique. I think there's some arguments that we don't really need to gown and drape and the like at the moment. I'll wait for that to become embedded in reality before I start doing something that's out on the edges of that bell curve that might make me feel slightly more implicated if I were to have a patient with a complication. One last note, and something that we actually all do and probably don't realise why. Why do we use 0.5% chlorhex spray as opposed to the 2% stuff that we use to put cannulas in? Well, there is an implication for chlorhex to cause an arachnoiditis, so we wouldn't want to inadvertently introduce that into an intrathecal space. Let your prep dry. I'm sure you've seen on the wards people using chlorhex for lumbar punctures. We should hopefully be able to advise our colleagues that they might cause a disaster, and whilst it's perhaps out of abject caution that we use lower concentrations of chlorhex for intrathecal and epidural and regional access, we do that for a reason, and we are in a modern healthcare system. Now, if you're super curious about the history of all these different spinal needles and their various permutations of shapes, sizes, lengths, bevels, cutting, not cutting, blunt, pencil point, etc., there's an excellent AAGVI essay, which is linked in the show notes, that explores this in greater and greater detail. I hope you forgive my indulgence on the history of spinal anaesthesia. I don't think there's anything else I can talk about on that matter. You'll be happy to hear. Always keep an eye out for descaling agents on your spinal needles, folks. Thank you very much for listening. Cheerio! Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.